Hello students, I am Dr. Sedubadi, Assistant Professor, Department of Conservative Dentistry and Endodontics, Vinaya Mission Shankaracharya Dental College and Hospital. Today I am going to discuss about Endocrown, a transition in rehabilitation. Restoration of a extensively damaged endodontically treated teeth always remains a challenge because while we are doing access cavity preparation, we will remove a lot of tooth structure so that the loss of dentin and the strength of the tooth get reduced. In such cases, post-endodontic restoration is necessary to mechanically stabilize those damaged tooth structure. By that, we will preserve and protect the existing tooth structure, also satisfactorily restoring the aesthetic form and function. But in such cases, what we will do, usually we will give a post and core. It can be either a metal post or a fiber post. But post has its advantage at the same time has a disadvantages also. Intraradicular post alone might not contribute to an increased retention of the restoration. In addition, post possesses several disadvantages such as it requires further removal of root dentin of already weakened tooth. Also, placement is limited in case of extremely curved or dilacerated canals. It is a technique sensitive procedure. All these are disadvantages of post. So, in all cases we cannot go with the post and core. For example, if the teeth is very badly broken and the root dentin is very thin, where the canal walls are very narrow, or in case of a calcified canal where you cannot go with the post and core, you cannot always rely on the post and core. In such cases, Endocrown is a good alternative. The Endocrown was first introduced by Bindle and Morman in 1999. These restorations are anchored to internal portion of the pulp chamber, thus obtaining macromechanical retention provided by pulpal walls and micromechanical retention provided by adhesive cements. What they are coming to say by this definition is these are endocrowns. Their main mechanical retention is by mechanical retention, which is cemented by the luting cements. Okay, macromechanical retention is by provided by those of pulpal walls. This is the pictorial representation showing normal crown and an endocrown. Normal crown where its margins rise over the cervical region of the tooth. The endocrown, its anchor rise within the pulp chamber. So let's discuss about what are its indication and contraindication. These endocrowns cannot be used in all cases of molars or premolars. It has certain indications and selective cases where it should be used. For example, molars exhibiting large coronal destructions. Next is short, dilacerated and fragile roots. In these cases, you cannot go with the normal post and core because already the root is short, so that keeping a post might not be indicated in such cases. If the root is dilacerated, which is curved, preparing a post over the dilacerated root is difficult. And the fragile root, there is a chances of breakage of root, so it is not indicated for post and core, but it is indicated for doing a endocrown. Next is extensive loss of coronal tooth structure associated with internal limited interocclusal space. If the patient has a deep occlusion, his occlusion is very limited, in such cases endocrown is the best choice to go with. Next is contraindications. It is contraindicated when the patient is having a parafunctional habit because the most preferable choice of material to use for endocrown is lithium disilicate, which is obviously a ceramic. So giving a ceramic restoration to a bruxism or other patients is contraindicated due to the breakage of the restoration and crown. So it is contraindicated with patients with parafunctional habits. Next, it is contraindicated if the pulp chamber depth is lesser than 3 mm. We should have at least a 3 mm of depth for its retention. So when patients having a minimum less than of 3 mm depth, it is not indicated. Also, it is not indicated in patient having cervical margin lesser than 2 mm. And whenever the proper isolation and adhesion cannot be assured, it is not indicated because all these are ceramic restoration which relies basically on its micromechanical retention by adhesive cements. So when there is no proper isolation and complete adhesion is not possible, you cannot go with these restorations. Okay, next we will discuss about what are the guidelines for endocrown preparation. I will explain in detail. First, we require a 1.5 to 2 mm of cuspal reduction. As shown in the image, the cusp should be reduced to 1.5 to 2 mm. This is the height of the crown which is going to place, and there should be a 90-degree circumferential butt joint margin with a width of 1 to 2 mm. Next, all cervical margins are placed as supragingivally as possible. And occlusal divergence should be present. There should not be any convergence because we are taking a indirect restoration. This is an indirect restoration in which impression is taken and the processes is fabricated. So in such cases, you need a occlusal divergence. Here the divergence required is of about 6 to 12 degree, and the internal line angle should be rounded. Smooth internal transition and relatively flat pulpal chamber floor with sealed radicular spaces. This is very important and ideal for requiring a smooth restoration and to prevent the further breakage of ceramic restorations. Here I am going to discuss about my cases in which the patient has came with a complaint and they are successfully treated with a restoration of endocrown. This is the first case in which 3-7 and 4-7 are endodontically treated and which requires a post-endodontic restoration followed by a crown. So I have opted for a endocrown due to the patient had a limited interocclusal space. Also the teeth was very badly destroyed due to caries and due to endo preparation. So I have opted for a endocrown. This is the lateral view of 3-7. Here in the slides I will be discussing both on 3-7 and 4-7. First I am going to discuss about 3-7. This is the lateral view of 3-7. This is the bite of the patient. In lingual surface there was a limited crown height. So crown lengthening was done in 3-7. After, the floor of pulp chamber was filled with a layer of flowable composite to obtain a smooth wall and to seal the gutta percha. Next is, this is the lateral view of 4-7. Next, the tooth preparation for endocrown in 3-7 has been done. Coming to 4-7, the distal surface of 4-7 was badly broken and there was no crown height. So I opted for deep margin elevation. Here the deep margin elevation was done using SDR bulk fill flowable composite. After placing a matrix band and a retainer, I have placed a SDR bulk fill flowable composite over the distal surface and I have built up a wall. The floor has been filled with the flowable composite. So that you can see in the radiograph, I have obtained a distal wall. You can see the radio opacity due to its SDR bulk fill. Following that, the tooth preparation for 4-7 has been done for endocrown. You can see the diverging wall and the bud joint preparation. Also, all the margins has been placed supragingivally. Following the tooth preparation, the impression has been taken using a polyvinyl siloxane impression material with putty wash technique. Following that, the endocrown has been fabricated. This is the lithium disilicate endocrown. Next, this endocrown, before luting, it has to be tried in the patient's mouth and to check whether there is any occlusal interference is present or not. Following that, then the endocrown is taken and the internal surface of endocrown was etched with hydrofluoric acid for 20 seconds and then rinsed with water and dried with an air syringe to obtain a white frosty appearance. Following this, the endocrown is next coated with a silane coupling agent for a 1 minute and then dried. This is what about treating the endocrown. Next, in coming to patient, the teeth has to be etched using phosphoric acid and then abundantly washed with water and then dried, then followed by application of bonding agents. Preferably 2 coats of bonding agents is applied and then polymerized for 20 seconds with light curing unit. Then after a complete and good isolation, the endocrown is cemented using a polymerizing resin luting cement, which is a dual cure resin luting cement, and is placed over the crown and also to the tooth surface and it's luted. Following luting, it is polymerized. So this is the pictorial representation following the final cementation. You can nicely figure out the clinical and correlate it with the radiograph. Okay, this is my case report. Now let's discuss about its merits and demerits. Coming to conventional post and go retained full coverage restoration, the disadvantages over that are it removes the excessive radicular dentin for post space. Also, it requires a preparation of ferrule, which removes removal of sound enamel and dentin. And it should have a occlusal thickness of processes minimum 1.5 to 2 mm, which less resists the occlusal stress loading. While compared to endocrown, the preparation does not require any removal of radicular dentin, so that in future the breakage of root is minimal. Next, it is a ferrule-less preparation. So you are preserving as much as tooth structure as possible. Here the occlusal thickness of the processes is more, so that you will have a more retention and more anchorage to the tooth surface, and also it withstands much occlusal loading. So I hereby conclude that Endocrown appears to be a promising treatment option for endodontically treated posterior teeth with extensive loss of coronal tooth structure associated with limited interocclusal space. This type of reconstructions, which is still uncommon, should be more extensively known and practiced. These are the references for the Endocrown. Thank you all for listening and watching to the video.